Today's lecture is on oronasal fistula, which we know is one of the biggest complications of cleft palate surgeries. By this lecture, the learning objectives are: one, will be able to define what is an oronasal fistula, be able to know the causes or predisposing factors that result in oronasal fistula, the various types of oronasal fistula, management or treatment of oronasal fistula, and the prevention of oronasal fistula. By definition, a fistula is an abnormal connection between two epithelial surfaces. Commonly, there are two broad groups. Commonly between, the first is where there is a communication between a hollow viscous and the skin, and this is referred to an external fistula, or between two hollow viscera. In this case, it is called an internal fistula. By this definition, an oronasal fistula is an internal fistula because there is a communication between the oral and the nasal cavity. Oronasal fistula probably is the commonest complication following cleft palate surgery, with reported incidence as high as 68%. For us to appreciate oronasal fistula in terms of etiology or in terms of what will lead to that, the vascular anatomy needs to be appreciated, because without blood supply, once blood supply is cut off from a particular tissue, necrosis results, and that area becomes dead and slough off. And when you have that in the palate, you end up with a fistula. Or if it's complete, involving the different layers of tissue, you end up with that. So when you have a normal anatomy, as shown on this screen, you have about 7 vessels and 2 key vascular anastomosis, which is found at point A between the descending palatine artery and the ascending palatine artery to the lesser palatine vessel, and at the second anastomosis, which is between the greater palatine artery and the anterior palatine artery. Once you have cleft, there is some disruption that you will not have this. So if you have a unilateral cleft palate, the vascularization is sort of, is an anomaly, and you don't have the complete anastomosis, especially on the cleft side. So if you notice on the screen, on the diagram there, on the cleft side, the B anastomosis on the cleft side is absent. So therefore, if repair is there, blood supply is precarious, and there's a tendency, if tissue is not handled properly, you end up with fistulation or necrosis, which will end up with fistula formation. In an incomplete one where it's bilateral, you have on both sides, the A is absent, as you can see here. Then the bilateral cleft palate, the vascularization is so much affected that you find in the middle, blood supply is relying on the premaxilla here. So, what are the factors that influence formation of fistula? The age of operation, if you do it too early, preoperative malnutrition in poorly nourished children, especially in an environment where a lot of them end up not having the best of the nutritional status. And more so that for those who have cleft palate, feeding, they don't tend to do very well in the course of their good. So we present with malnutrition. Then when you have a wider cleft, or especially the both type 4, which are quite wide, it means that repairs will be under tension, require so much of dissection that can lead to tissue damage. Where you have high palatine index, the ratio between the breadth and width of the palate, we show that those with high palatine index tend to end up with they have the higher tendency of developing coronasal fistula. Then surgical technique, if it's quite poor, closure under tension, compression, stretching of the pedicle, vascular thrombosis, bleeding, and hematoma. And once there is a damage to the vascular supply of the tissue or the flap, can lead to what necrosis. Infection can occur in some situations that can encourage necrosis and fistula formation, as well as the last point is foreign body irritation. There are several causes of coronasal fistula, and this can be classified under the 6 categories: iatrogenic, trauma, infection, post-resection of tumor or cystic mass around the palate, poor patient's compliance to post-op instruction, and rarely you have rhinolithiasis, which has been reported in some few cases. So we just take them one by one now. Iatrogenic, in this case, is related to the surgeon. This is related to the surgeon trying to repair cleft lip or palate. There could be osteotomies and other surgeries that can lead to damage to tissue there. Rarely you can have some situation where people abuse cocaine. You know what cocaine does. Causes a lot of vasoconstriction, leads to decreased blood supply, and lead to necrosis of tissue. Cases of abuse of cocaine has been reported as one of the causes of coronasal fistula. One, two. Okay, so the next step, like I said, is the traumatic causes, usually as a result of maybe injury, road traffic accident, and the traumatic causes which result into fractures like developing to coronasal fistula. Usually the instrumentation can maybe slipping of instrument in the course of extraction, or in terms of instrumentation for one surgical procedure or the other can lead to fistula formation much later on. Infections can occur that Hello?
Well, I'm getting you, Prof. Please, can you go ahead? We are listening to you.
Thank you very much. So such infection, commonly like the fungi, you have rhizopus, mucormycosis, aspergillus species, candida species, and the rest can result into fistula formation. Others are like the spirochetes, especially in syphilis. For bacterial causes, commonly the lepromatous leprosy bacteria can result into coronasal fistula. For parasite, the main example is leishmaniasis. And in our world, especially in Africa, we have Noma or Cancrum oris as one major cause of coronasal fistula. Usually, this infection is polymicrobial. The fourth is you could develop coronasal fistula following resection of some masses or cysts, and the final outcome of it might result into a fistula formation. The fifth cause is as a result of poor compliance by patients on post-op instruction, like oral hygiene and other things. So you might end up having with oral infection that can lead non-absorbable materials. This can grow gradually and now cause necrosis and formation of coronasal fistula. So classification, coronasal fistula can be classified based on the size of the fistula into small, usually less or equal to 2 millimeters, medium 3 to 5 millimeters, and large fistula, which are usually more than 5 millimeters. They can also be classified based on the location, either as anterior fistula, mid-palatal fistula, fistula at the junction of the soft and hard palate, and soft palate fistula. There is a classification, that's the Pittsburgh classification system, which is based on the position or location of the fistula, and they are classified into type 1 to 7. This Pittsburgh classification system has allowed for standardization of presentation and comparison. It has helped in comparing different options of management. The type 1 usually not too common, restricted to the uvula. Type 2 soft palate, type 3 junction between the hard and soft palate. Type 4 is located at the hard palate. Type 5, the junction between the primary palate and hard palate. Type 6 is the lingual alveolar location, while type 7 is the labial alveolar location. The next figure shows the scheme, the drawing to explain this. And this classification has been the only standard classification so far on oronasal fistula. This is just an example of oronasal fistula. So, management of oronasal fistula. Management entails history, examination, investigation, followed by the surgical. To be able to make diagnosis, one have to consider these very important features. Usually, patients with oronasal fistula have hypernasality of their voice because of escape of air during speech, which can be audible. There is sometimes nasal regurgitation of fluid, lodgement of food particles in the nasal cavity, air escape from opening when the patient blows his or her nose, unobstructed penetration of gutta percha paste through the opening into the nasal cavity. And if one does occlusal radiograph, you'll be able to demonstrate such defects. So, depending on the features, we find usually the openings varies. So, if the areas exceeding 4.5 to 5, like I said earlier, they tend to interfere with the speech, causing nasal hypernasality, audible nasal air escape, and weakness in the pressure consonants, those hard consonants like the B, D, T, G, in pronouncing words with such letters, they tend to be very obvious. So therefore, if you have fistulas of those magnitude, even if it is quite small, few millimeters, they can affect speech. So one can assess simply by covering those fistula with dental wax or any palatal plate and observe the speech by that individual. Once you do that and you find a difference, you know that no matter how small it is, it can affect. Then the other things, the nasal regurgitation I've said, and the other secretions will be some additional things that will help in the diagnosis. What do we do in preparing for operating on this category of patients? There should be adequate preoperative assessment. Most of the time, the osseous defect is much larger than the soft tissue defect. One should assess the size differences clinically using some probe under local anesthesia or radiological, or using both assessment, that's both the clinical and radiological assessment. But one should take note that one should only go ahead with the repair 6 months after the primary surgery or the previous surgery. One should prepare that if the cause of the fistula is infection, one should treat adequately. And one should take note that scar tissue beyond the previous incision are just epithelialized scar. And most of the time, if you incorporate them, they tend to what break down because they are not normal tissue. If possible, one should be able to assess where the vessel is using handheld Doppler. What are the surgical principles that will guide someone so that there won't be a repeat of fistulation or another fistula, which will end up, one will end up with a cleft palate cripple? The repair should be preferably done at least in 2 layers or 3 layers, depending on the location. Tissue should be well vascularized and closed, free of tension. Double or triple layer provides adequate coverage. There is added strength as well as vascularity. The choice of flap for the repair will depend on certain factors. First, the patient, the age, the general condition, the nutritional status. Second is the defect itself. Where is it located? What's the size? What's the cause? What's the severity, associated scarring, and how long that defect has existed? The third is the surgeon. How familiar is the surgeon with the method, the experience, his or her dexterity, and how much experience he has with different types of procedures. The surgical techniques usually depends on the location, size, and extent of the fistula and the quality of the local tissue. They vary from the use of local flaps to the use of free tissue flaps that are usually local, regional flaps. There are additional tissues that can be used, like the cartilage, fascia, dermal fat, graft, acellular dermal matrix. All these can be incorporated between the pockets of the nasal and the oral layer to be able to achieve closure in some cases. So let's go through some of the flaps. First is the small local flap. You can see from the diagram, it's for use of local flaps, especially in Yiltok type 4, can be closed with a turnover flap so that you'll be able to have the nasal line and be able to use the mucoperiosteal flap to cover the oral side. Even the flaps can be reversed and tunneled to be able to use a picture to show just local flap. On the left of the screen is the fistula, and on the right, the closure. The second technique is a complete redo. In such situation, one is going to just bring down the entire repair and close it as if one is doing a fresh repair completely. The best are usually the mid-palatine nasal fistula that is surrounded by adequate palatine tissue and associated with pharyngeal incompetence. A complete redo corrects both the problem of the fistula and the DPI itself. The third technique or method is the use of buccal mucosa flap. This method is used commonly for a number of fistula, commonly the fistula type 3 and type 4, as well as 4 to 7, depending on where
Hello, Prof. I think we lost Prof. Maybe having some internet issues. Prof, are you getting me? Do you read me? Hello, Prof. Are you getting?
Yeah, thank you very much.
Hello, Prof.
I lost connection, so I hope I'm back.
Oh, yes, Prof, you're welcome. Continue, Prof.
Okay. I stopped at the number 4, the fourth example of surgical technique, the use of flap. The mucosal or my mucosal flap usually raise a mucosal flap or incorporating even muscles so that one will be able to achieve closure. I said the fourth and the fifth are related. So you have the fifth one, which is a facial artery mucosa flap, my mucosal flap, which was first, it's a versatile flap and be able to raise it to close both anterior, posterior. In some situations, even some conditions in the floor of the mouth, this flap can be used for closure. It becomes quite handy when one needs it for patients that must have gone through several procedures who can be classed as cleft palate crippled. And in this procedure, one will be able to trace the vessel, the facial artery vessel, using handheld Doppler to be able to locate it, raise it, and be able to use a reasonable length of pedicle to be able to close. So they are usually the width I use about 2 to 3 cm of my mucosal composite tissue and be able to use it. And one can use it to close, achieving very good closure. Then the sixth procedure that can be used is the tongue flap. This was first described more than 50 years ago. It's a 2-stage procedure. Even children have been found to be tolerant to this kind of procedure. First, raise it up, raise the flap from the tongue, take it to where you want to take it, insert it, and within 10 to 14 days, that can be, the pedicle can be, devascularized. By that time, you expect that the recipient side will have taken. Usually, it can take up to 6 millimeter thickness of the tongue tissue without affecting function. And usually, a good nasal layer repair is a prerequisite for the success of it. Usually, there is very little or no donor side mobility. The main complication is usually hemorrhage and sometimes spontaneous detachment. But if it's well anchored, one will expect less of that problem. Then the seventh, which is the use of free flaps. The commonest has been the free forearm, radial forearm flap. And these have been, in some situations, pre-laminated. That is, you raise it, put a skin graft so that it will be able to take care of the nasal layer and before detaching and do your free anastomosis. There are conditions where you might need non-surgical management of such conditions. And usually the indications are where a patient has decided that he has had enough, has undergone several procedures without addressing the problem. Usually such cleft palate cripple. But like the tongue, the free flap address that once somebody has the expertise on that. And the other condition where you use non-surgical is where the person is no longer interested. And there are options like the orthodontist may design a plate to cover the defect. And such components can be used, incorporate certain teeth to it. So you could have options that no expertise to undertake such expensive procedures that requires expertise. One can opt for the non-surgical procedure, sometimes to buy time and refer appropriately where an expert can be able to handle that in a long time. So preventing oronasal fistula, a number of measures can be undertaken. Having looked at all the things I've said, some of them that can be done is: one, nasoalveolar molding. This will help in narrowing the cleft palate. Narrowing it will enable, at the time of repair, to close it without tension, to close it without, putting the pedicle under stress that can lead to damage or thrombosis. Then preoperative nutritional rehabilitation of malnourished children will go a long way in helping to prevent oronasal fistula. Then the fourth is applying excellent surgical techniques with gentle tissue handling. This will prevent tissue damage, flap necrosis that can eventually lead to fistula formation. These are my references for that. Thank you very much. Merci, obrigado.
We want to say a very big thank you to Prof. And it has been a very, very wonderful presentation. Despite the challenges of technology with internet, Prof has been able to pull it through. It's very interesting. I have, Prof, we have some questions that you will probably go into the question and answer session. Please keep your questions coming. Keep your questions coming.
Okay.
Your questions at Q&A, your comments at the chat room. There is a Dr. Adelida is asking the timing of fistula repair after primary surgery. Prof is asking, what is the timing of your fistula repair after your primary surgery?
6 months. Shouldn't be not earlier than 6 months.
Prof, can you give us your... Yes, Prof, we get you. Can you tell us the reason why you should have to wait until 6 months?
Yeah, usually you expect that all the inflammatory process have gone to a kind of like 0 level, so that if you have to do it much early, you're going to develop more problems. So you will have allowed most of the edema and all the inflammatory processes, so that the tissue will have gone to a level that you'll be able to handle it easily. If you do it much early, there will be breakdown almost immediately.
Okay, Prof. We want to thank you so much for that explanation. Here in Yaoundé, I do repair of fistula after 3 months. I follow the smitering protocol. After 3 months, I redo the fistula, and I think we have a good result. So, Prof, I don't know, maybe we look at it from 3 to 6 months. Once you're sure that there is no contraindication, if that is possible. What do you think about that, Prof?
Well, everything in nothing is cast on gold. Cast there is no strict rule. If you can do anything that you'll be able to achieve it and share those experiences, that's fine. But generally, the principle I've used is not just on cleft lip or palate alone. Generally, there are certain procedures you want to hold on first. But like you said, if you've had that experience, one will try it and see too, so that we'll be able to handle it. But like I said, the primary purpose of doing this is to prevent it from even happening. So if one can go ahead to follow all the basic principles so that you avoid even the fistula forming. It is when you have fistula formation and you want to allow for such, breaks so that you be able to. I know, like in hypospadias, you have the same similar kind of thing. You wait for some time first so that you'll be able to do the repair, and because you wouldn't want to go several times on that. But if you are only doing such procedure alone as a primary thing, your experience will be different from somebody who is involved in so many other procedures, so that you'll be able to achieve this. The ultimate is to prevent the person from going through those harrows of surgeries again.
Well, Prof, thank you so much. We are still waiting for your questions. I have another question for Prof. Prof, tell me, what is the most versatile technique you will use that you can tell a young surgeon on this SMITRAIN program that you can use for the treatment of oronasal fistula? What technique you've already told us about the location of the fistula. You've told us about the size of the fistula. But as a young surgeon and you're faced with a fistula, what do you do first? Are you going to go with local tissue? Are you going to, what is your opinion, your take on that?
Yeah, it all depends on the location. There won't be a hard and fast rule on any of them. If you have it more anterior and you think the buccal mucosa will solve the problem, fine. If it's around there that you can do local tissue, fine. But if it's something that is in the middle or the soft palate that you probably have to do a redo, it's all fine. So it all depends on the location, the size of the fistula, and basically those two are the major thing: the size, the location of the fistula, because that will depend on where you'll be able to mobilize your soft tissue to be able to cover there. If it's where you cannot use local tissue. But I think for somebody who is training is to see how much you can do with the local tissue. But like the tongue people run away from it. These are doable things that somebody can go ahead to do it. So in the long and short of what I'm trying to say, it depends on the location and the size of the fistula.
Please keep your questions coming. Our question and answer is still very much empty, and this is a very, very important presentation today because we are going to be meeting it every time we repair clefts. If you're into cleft, you always meet it. Prof, let me ask you this as we will keep waiting for the questions. In the Pittsburgh classification, you talked about the fistula between the lip and the alveolus. When you have a fistula, like we just call it below lip fistula, what do you do? What's your approach on that situation? Do you go trying to repair? What do you do? Do you break down the lip completely and redo in order to close the fistula, or you just concentrate on the fistula?
Hello, I didn't get you very well.
Yes, I was saying that with respect to the Pittsburgh classification, the fistula between the lip and the alveolus.
Yes.
What is your approach to that fistula? Because we find it very, very common, especially if the surgeon is not very good at his primary repair. What is your opinion on that? How do you solve that?
Yeah, what I'll do, I'll use the buccal mucosa because that's the closest where I can raise a flap, because it's between the alveolus and the buccal mucosa. One will be able to raise a buccal mucosa flap that will be able to snug it and line it and be able to achieve closure there. The good thing with the oral cavity is it has very good blood supply, and if you're able to get those tissues there and close that, you'll be amazed at the amount of healing that can happen there.
Prof, we were in Ethiopia at one time and under SMITRAIN, and we had a discussion on this. And I remember Dr. Onguti brought a proposal that in such a case, you should completely open the lip and reconstruct it in 3 layers. You have the buccal mucosa, you have the muscular layer that gives support to the floor of the nose, and then you have the skin that you put on top of it. What do you think about that?
Okay. Yeah, I agree with that because one, the aim of almost like I said much earlier, repairs should be at least 2 or 3 layers depending on where you find the defect. So by doing that, you'll be able to separate the nasal cavity from the oral cavity and be able to have good tissue that will be able to align that place completely. So if it means complete breaking down so that you repair, because sometimes if you want to manage to just say that's the closure, you might eventually not achieve. So sometimes complete opening of that area complete so that you'll be able to seal the nasal cavity and separate it from the oral cavity. I think I'll go for that if that's what will achieve it.
Okay, thank you very much, Prof. This is so that the young surgeons on the team on board will be able to learn and know certain things. Please keep your questions coming. Our chat room is still very empty. Our comments are not coming up. Prof, I still have more things to ask you. Now, in the repair of a soft palate fistula or in a posterior fistula, and you are going to use a tongue flap, what will you ask? Will you use an anteriorly based tongue flap or a posteriorly based tongue flap? What is your, on what condition will you be able to use anterior or posteriorly based tongue flaps? And do you find it easy with children?
It's not easy with children, except they've reached a level of, discernment or anything, because it's the mouth. It's not very easy to control, and there's a tendency, if it's not anchored very well, it might just detach itself, because children need to feed, they need to move around. They are in the oral phase of their development. A lot of it depends on the mouth. The use of whether anterior base or posterior depends on the location, because the issue is that you should be able to have adequate mobility that will be able to cover where the defect is. So if the defect is more posterior and a posterior base flap will solve the problem long enough to be able to cover whether anterior or posterior. Most of the time, you find out that the anterior base flap and will be able to reach whichever location you found in the palate. Yeah.
Okay, thank you, Prof. We have some questions coming. There's a question from Dr. Nenkam Ebenezer Jean, who is in Garoua, in Cameroon. He says, merci pour la présentation. Avez-vous un protocole alimentaire en post-op pour éviter de fistule? He says, thank you, Professor, for your presentation. Do you have a dietary protocol for in post-op in order to avoid fistulas? Nasal fistula? That is his very first question. Then I will ask the second. Il says, merci le professeur pour sa présentation. Avez-vous une préférence pour une qualité de fil dans la présentation, dans la prévention des risques de fistule après la chirurgie des fentes palatines? He says, thank you again, Professor, for your presentation. Still, Dr. Nenkam Ebenezer Jean, who is writing from Cameroon. He says, do you have a preference for the quality of sutures that you use during your primary repair in order to prevent fistulas? Hello, Prof. Did you get the question?
First, the protocol for the first question, that's the protocol for feeding. Usually, I don't have much strictness or what, but that whatever, as soon as is possible, the child feeds, and usually is followed by oral care so that there is less of debris that will be within the oral cavity, because once you raise flap, you have some raw areas that food particles can be there. Or in some situation, one uses nasogastric feeding in the early part. You find out within few days, the area heals very rapidly. That sometimes you'll be amazed if you make the mistake of leaving some packs there. By 1 week, it will epithelize and leave that, and you end up burying foreign materials there. So not strictly, but if where is necessary, one can use an NG tube, that's nasogastric tube for feeding in the first few days, and allow more of liquid diet, not very hard, and following every feed, there should be oral hygiene, some gargling and other things, especially for patients that can obey orders. For those who cannot, you might have to leave the NG tube for some few days, and subsequently the patient will be able to continue. Then the second question, I didn't get very well because of the network. If you can rephrase it.
Yes, I can refrain the second question. He says, thank you, Professor, for your presentation. Do you have a preference on the type, the quality of sutures you use in preventing the risk of oronasal fistula during cleft palate repair?
Yeah, I try to absorbable sutures, things like monocryl, bicryl, and those are the ones I prefer using. Of course, I avoid things like catgut and other things, though they are quite difficult. They are cheaper to get, but there are limitations of what you're going to do. So I tend to stick to monocryl and bicryl. And depending on this, most of the time one tends to use the 4 suture sizes. So those are the sutures I tend to prefer using. Thank you.
Yeah, Prof, thank you so much. I work with Dr. Onguti, and I learned something from his practice. The post-op management of patients that have cleft repair, especially those that are bigger. And we try, and that is what we've adopted in our as a protocol when we do cleft repairs, especially when we go out on missions. We make sure we put the patient on a semi-solid diet for the next 1 to 2 months. It is quite a difficult thing, but we make it like a religion to the mother, and the mother will respect it. That no solid food should be taken. For those children who are sucking their fingers, we try to glove them. We put a glove drain, a glove, something on their hands to make sure they don't put their hands in their mouth. For those who are a little bit big, we tell them, make sure you don't eat anything hard. We don't want them to eat any hard food. Nothing like ching-ching, anything that which is hard. We try to avoid peanuts, all that. We try to avoid the patient from eating that. Then we also try to avoid, a very common thing is trauma, as Prof said. That is, we try to avoid a patient brushing their mouth with a toothbrush. So when they're going to use a toothbrush, especially in children, we want the adults to assist them, because just by trying to brush, it can cause a trauma on that place. Prof, what do you think about that protocol?
Yeah, I think it's a good protocol. Just to add to that, I think we tend to encourage the use of highly nutritional semi-solid, more like pap. There's this plumpy nuts that we get and use sometimes for some of our patients. The plumpy nuts are highly nutritious pap made of peanuts, and it has high protein content. So, but we usually have tendency to have difficulty in the supply, but we try to train the parents, the mothers, to be able to, improvise on that, using like pap that will have like fish that are blended and mixed, so that you have highly nutritional liquid diet that will be able to help the children. So, but we then tend to take it to that length of 2 months. We usually within 2 weeks, if there's going to be a fistula, it will have shown itself. If there's healed, it will have healed by that period. So even subsequently, we encourage them to do that. We found out that we have used that one, especially for those of us who practice beyond just that bones patient. Those plumpy nuts have been very, very useful in the recuperation of our patients.
Okay, Prof, thank you very much. We have one request from Dr. Adelida. He said, I humbly request that Prof, you be able to share with us a video of a tongue flap repair or a live procedure, if you have, whether it is both anterior or posterior. So someone is interested in tongue flap, and it's a very important arsenal we need in the treatment, our quality care of cleft patients. I want to say thank you so much, Prof. You're such a wonderful man, sir.
Thank you very much.
God bless you, sir. God bless you so much.
It's my
And
pleasure. Thank
it's
you
been a
very
real
much.
pleasure to listen to you and to talk about orofacial oronasal fistulas, which are something we will live with as long as we do cleft lip repair. And it's very important for us to teach the young surgeons who are coming so that they should be able to handle this. Thank you, Smile Train. Oh, thank you so much, Smile Train. It's so wonderful. You've changed our lives. Thank you, the West African College of Surgeons, for giving us this platform on which Smile Train can enlighten, educate, and lead us in the cleft care.